5 seconds to do that. All right, the floor is yours.
All right, thank you, Doc. Good evening, everyone, and welcome to all those who have joined us via the various social media platforms on the Dr. Fundi channel, and welcome to all our special guests and panelists who come from diverse healthcare backgrounds. My name is Pelokazi Nyati. I also would like to welcome my co-moderator, the very capable Dr. Siviwe Mila, who is a medical advisor at Proactive Health Solutions. I also would like to welcome and thank our host, Dr. Fundi Lenyati, also known as Dr. Fundi, who has offered his platform so we could continue with a conversation that started on the 18th of May, 2021. Now, this conversation was about academic and workplace bullying during undergraduate and postgraduate training in various healthcare professions in South Africa. But the webinar on the 18th of May mainly addressed issues within the medical fraternity. So because participants who were following this conversation in the previous webinar requested inclusion of other health professions because they felt that these issues were also affecting them, and that these also needed to have a platform for everyone to voice their views or contribute to these conversations. So even more disturbing was some of the things that came up during that period and later, where we found that some of the people were raising issues about bullying between the various health professions, and where some professions were seen to be inferior and others were seen to be superior. And then those individuals would then mention that they felt that there was bullying coming from their colleagues, coming from other health professions within the same healthcare space. So this, they expressed, was something that was happening both during training and also in the workplace during their interactions with their colleagues. So tonight we'll have an opportunity to address these challenges, which continue from the previous discussion, from the previous conversation. And we'll also get new contributions, hopefully, and insights that people will share, which they will base obviously on their lived professional experiences. And so allow me to hand over to Dr. Mila, who will introduce our panelists, and so that we can begin our conversations. So over to you, Dr. Mila, and thank you.
Thank you so much, Ms. Nyati. We'll call her Sis P. So like, yeah, I'll give you into the office talk. Thank you so much, Sis P. Good evening, everybody. As said, I am Dr. Siviwe Mila, a medical advisor at PHS, Proactive Health Solutions, which is a wellness solutions company. And I'd like to welcome our panelists. I'm just going to read a small bio about each one of them. They are well-accomplished people, and we have done great research to get a vast variety of the different professions within the health space, as Ms. Nyati has said. Firstly, we've got Ms. Liesl Anthony, who will be our keynote speaker for today. Ms. Liesl Anthony is qualified and a very experienced clinical psychologist who obtained her master's MA degree at UWC, University of the Western Cape. She also holds a master's in philosophy degree in workspace, HIV/AIDS management from Stellenbosch University. She's got extensive experience as an employee wellness practitioner who led the Northern Cape Employment, Health and Wellness Subdirectorate at the Office of the Premier for about 12 years. Currently, she's in private practice and she's completing her PhD degree with the University of the Western Cape. Then secondly, we've got Dr. Diana van Staden. Dr. van Staden is an academic and a researcher at the University of KwaZulu-Natal. She has served on the profession of optometry for the last 20 years in various capacities. She's passionate about the advancement of eye health in the African continent. She's encouraged eye care leader with an interest in health professional education and development. So she'll help us see better today. Then, sorry, that was my reminder actually for Mrs. P. Now mine starts. Then we've got Mr. Mashudu Nemakanga. He's a qualified occupational therapist who graduated from Sefako Mahato University, which was formerly known as Medunza. He has more than 10 years of work experience as a practicing occupational health therapist clinician. He currently holds a master's in public health through the University of Limpopo. Currently works as a lecturer in the occupational health department at Sefako Mahato University and is studying towards his PhD at the University of Pretoria. Then we've got Ms. Babalwa Pamla. She's a qualified pharmacist who completed her bachelor's in pharmacy degree at the University of Durban Westville, now called UKZN. So you can tell we've got experienced people. It was previously known, but now known as. She also holds a BCom degree in marketing and management through the University of South Africa. She's got a 15 years experience in working diversely in the pharmaceutical industry, and she has worked in the clinical research, production, quality assurance, regulatory affairs for local and multi-international companies. She currently works as a regulating officer manager for Baxter Healthcare, and she's responsible for the SADC region. Then we've got Mr. Ntsikelelo Phefile. He's a qualified physiotherapist who graduated from the University of the Western Cape. Western Cape, you're going to shine today. Hey, I feel like, yeah, there's a there's like nepotism somehow, Western Cape. He holds a degree in postgraduate diploma, public health, health policy and management from the University of Witwatersrand, as well as a master's degree in rehabilitation studies from the University of Stellenbosch. He has an extreme and extensive work experience in public and private sectors, as well as in academia across all South African universities. He has recently joined the Department of Rehabilitation and Health Sciences, mainly the Division of Physio at the University of Stellenbosch as a senior lecturer, and he is responsible for heading up clinical services and social impact portfolios, as well as undergraduate and postgraduate teaching in neurological rehabilitation. And he's also pursuing his PhD at UKZN and looking to develop a model to guide employment outcomes for people with spinal back problems in South Africa. Then we've got Ms. Musola Zona. She's experienced in a mature professional nurse. She's the mature Miss Nightingale stock. Miss Nightingale with the lamp. I'm not sure we still have that. So that's just by the way. Her long work experience spans over more than 4 decades, 40 years, having worked in almost every province in South Africa and the various healthcare institutions. She also has had work stints abroad, mainly in the United Kingdom. She has worked as a nursing manager and a nurse educator at the colleges of nursing, including the University of Cape Town. She's passionate about education and is an empowering tool for everyone to advance in life. And finally, she believes in good governance and quality assurance. So I believe she's going to give us a lot of pearls of wisdom for how do we become better and with the bullying. And then lastly, but not least, we've got Dr. Sandile Bongose. He obtained his basic dentistry undergraduate degree at the University of the Western Cape. He subsequently pursued further studies and obtained a master's degree in prosthodontics. Oh, I hope I said that right. That's like sounds like a tongue tie. Prosthodontics from the University of the Western Cape. He has worked in the private practice as a dentist and now as a consultant in prosthodontics at the University of Witwatersrand and has been holding that to date for about 7 years. And he's currently in the academia space, the Faculty of Dentistry at Sefako Mahato University. Thank you so much. I think we will start with Ms. Liesl Anthony, who will be our keynote addresser for today. Is there anything I'm leaving out? Yes, oh, there you can able to share your screen. Ready when you are, Liesl.
Okay. Unmute, please.
Oh, technology. Thank you. Are you all able to see my screen?
Yes.
Okay, all right. Thank you for what a very wonderful introduction, and I think we are quite a bunch of professionals that we have here today. So I'm looking forward to a very engaging discussion and to hear, about everybody's experiences. Like the moderators has mentioned, it's part 2 of the discussion that happened. So for anybody that didn't, get to part 1, it's on the Dr. Fundi YouTube channel. And I think, there's a lot of things that was said and a lot of different discussions that were had. So I would like to just direct everybody to just go and have a look at part 1. Okay, so briefly today, what is bullying? And, Dan always was really the pioneer who started research on the field of bullying, and he's had over 30 years experience in researching that. And he has typed it as intentional negative behavior. So it's something that is done intentionally towards somebody else. It typically occurs with some repetitiveness and is directed against the person who has difficulty defending himself or herself. So it's not a once-off event. It's something that perpetuates, and it happens over and over, and it has a negative effect on the person who is the victim of this bullying. It's an antagonistic interaction of an individual in a perceived position of power over another. Just want to move this out of my way. And the bully is normally an older person. It's a physically dominant person. It's normally a superior at work. And it's a person that really exudes an effective posture of intimidation. And I'm sure we can all connect with, who that person might be. So it's ultimately bullying occurs from a position of power. One person is the person that is being minimized, it's subservient. So whether real or imagined, and this is from the bully side, whether real or imagined, he has the illusion of power over the victim. In most cases, the person has excessive power. In other cases, the person perceives himself as having that power. So it's also said that it's embedded within the history, norms, and practices of the health professions institution. And the negative impacts are pervasive. And that is actually quite scary to think that in 2020, research has found that bullying is really embedded and ingrained in the institution that is supposed to train. If we look at the bullying cycle, in the center we have the victim, and it really says we start with either the bully or the bullies, because there could be a number of people doing this. They start the bullying and they take an active part in it. Then we have the followers, also called the henchmen. They take an active part, but they do not necessarily start it. And then you have the supporters, or the passive bullies. They support the bullying, but they do not take an active part in it. And then you have the passive supporters. They like the bullying, but they do not display the open support. So, and I guess in the workplace, there's a lot of people that do that. Then you have your disengaged onlookers. And they are the people who really witness what is happening, but they don't really take a stance. They don't say anything. They don't speak up. You have the possible defenders. They actively dislike the bullying, and they think this shouldn't be happening, but they do nothing. They sit back. And a lot of time it's out of fear that if I say something, this might happen to me. The attention might turn to me. And then you have the defenders of the victim who dislike the bullying, and they help and they try to really assist with the victim. They're the ones who say we need to speak out, we need to really address the issue. And that is really the cycle of bullying and the people that are involved in it. So it's not just one simple person. It's really an institutional systemic issue that happens with a lot of different role players involved. And it's really what we call the silent epidemic, because nobody's talking about it. Everybody knows about it, but nobody says anything. The World Health Organization has actually said that it's a global phenomenon, and it's becoming a major public health problem. That was in 2010, and in 2020 we're still experiencing that, and research is still being done. There's a multitude of research out there on bullying, especially internationally, but it's come to the South African shores as well. We're now actively investigating workplace bullying and workplace bullying in the health sector. So like I said, it's been called the worldwide silent epidemic. And studies have suggested that bullying occurs much more frequently in the healthcare sector than in any other sectors. And they are theorizing that this may be due to interpersonal and emotional nature of the healthcare work. Also because of the hierarchy of healthcare institutions. There's always, this thing of who is on top, is it the medicals? Is it the, whoever we regard as in the hierarchy? The system has created this hierarchy. And then also the conflicting priorities of multidisciplinary teams. So here we see again, the one team or the one profession that might be bullying another profession. Although we find a lot of bullying within specific professions, one professional to another. And a lot of us have been subjected to that. There was a book called A Psychiatry Interrogated, and it was published in 2016. And it's actually looked actively at, one chapter was delegated to look at bullying within the healthcare sector, and specifically in the caring professions. And they looked at social workers as well as psychologists. And it was found that, both psychologists and social workers have experienced bullying from their own professions. Or their own colleagues. One was a faculty member at a university. And when they spoke up about the bullying, they were labeled as being mentally ill, and it was framed as being incompetent, and they were emotionally vulnerable. So there's a lot of pathologizing that happened within the caring professions itself. So it seems like no profession is immune to this. One study actually looked at what are the risk factors. They looked at what the bullying behavior was, and they looked at the different type of outcomes. So in terms of the risk factors, they say there are three. You need to look at the organization, you need to look at the perpetrator, and you need to look at the victims. And they said in your organization, it was really about a poor working environment. It was a stressful environment. There was job ambiguity, not really knowing what my role is. Where do I go? Who do I report to? Shortage of manpower and poor leadership were all factors that played into the organization, and highlighted those as risk factors for bullying to occur. The perpetrator, as mentioned, was seen as a powerful figure, highly influential, much more authoritative, and normally took on the role of the oppressor. And victims were normally younger people. They were inexperienced. They were less assertive. They had lower confidence, because a lot of them were, because of their inexperience, and also because some of them were students, and some of them showed a vulnerable personality, which were obviously exploited by the more powerful oppressor. In terms of bullying behavior, they looked at what does that entail, and it was a lot of belittling remarks, persistent criticism, intimidation, humiliation. It took on quite a range of behaviors: withholding information, not sharing information, excluding the person or isolating the person, work overload, removing some of the responsibility, work that were assigned under the competence of the person, being shouted at. The person was given a lack of control over what they could do, even though they had the competency for it, and they were underutilized. So as you can see, bullying can take on a range of things which are not always physical, because we see that we find type of bullying that are verbal. There are verbal bullies, which are really the insults that you get, the constant criticisms. And then there are bullies that are more physical in the workplace as well. In terms of the outcomes, there's a physical impact, and emotional, and an organizational, and a patient impact. And a lot of people experiencing bullying complain of headaches, respiratory conditions, worsening of chronic conditions that they already had, and sleeping difficulties. Emotionally, they expressed anxiety. And that's where the respiratory conditions also come in, because the heart palpitations, their difficulty breathing, they were constantly under stress and pressure. Depersonalization, not feeling like themselves, not questioning themselves, questioning their identity, questioning their role, a lot of burnout symptoms, and then also post-traumatic stress. in many of the more severe cases. The organizational impact, it actually led to an increase in absenteeism. There were lower job satisfaction, lower productivity, a higher intention to quit. There was increased staff turnover rate and an increased organizational spending in recruiting and training new nurses. This was specifically on, the study was done specifically on nurses, but as we've seen in the previous, in part one, this is not just related to one specific profession. It's across the board that this is experienced. The impact on patients was that, the professionals did some errors. There were some errors in their judgment and poorer patient health outcomes because they were, because of the anxiety that they experienced, because of their own physical symptoms. So another study in 2019 looked specifically at the health outcomes of bullying. And they looked at 45 papers in the review, and it included a range of medical professionals, nurses, doctors, midwives, people that looked at the elderly, the allied health professions. They were clumped together, ambulance personnel, dentists, healthcare assistants, and nutritionists. So all of them were, research was done with all of them to really look at how do they experience outcomes, health outcomes after being bullied. There was a range of mental health implications, like with the previous study that just focused on nurses. They reported depression, burnout, psychological distress, anxieties, and even suicidal ideation and suicidal attempts. In terms of the physical health implications, it's also similar. There was insomnia, there were sleep deficiencies and changes in how they were sleeping, headaches, gastrointestinal problems, nausea, and they took a lot of sick leave. So we can see that even from 2016 and to 2019, the similarities are the same in the studies that are being conducted. In terms of what are the recommendations, how to address bullying in the workplace, and this study said it's more than words. It can't just be words. There need to be active things done to address this. This study specifically looked at bias and discrimination, but we know that discrimination and bias sometimes are some of the reasons why people are being bullied as well. So what they're saying is you need to create systems to identify and address bias and discrimination, or bullying in this case. You make the reduction an institutional priority. It should be a priority of your organization that we're going to address this, we're going to reduce this, and ensure comprehensive curriculum to actually actively reduce bullying in the workplace, ensure diversity in the health professions, and create institutional culture of respect, inclusivity, and equity. Recommendations that has come from a South African study that was published in 2020 looked at really three things that needs to be recommended: organizational culture, support, and management criteria. In terms of the organization, they say ongoing efforts by the faculty leadership to operationalize the transformation. There should be consequence management for negative workplace behavior, and there should be dialogue, continuous discussion between management and academic staff on diversity and social cohesion. And that there should not be there should be little recourse when this happens. And they actively campaigning for the appointment of an ombudsman or a facilitator, unrelated to your faculty or to your university, to really address these issues. In terms of managers, they are saying profiles of managers should be carefully considered to look at how to mitigate the impact of bullying. Training for managers in diversity and enhancing emotional intelligence should be considered. And there should be ongoing coaching and mentoring. And once again, specifically related to emotional intelligence. They're also saying there should be a greater support for academic staff. And in this case, relating to all the different professionals as well. A greater support for all of them who experience physical and the mental health consequences of bullying. And they should have access to reporting channels to enhance their mental and physical health services. So bullying is rife, bullying is prevalent, bullying is there. It's something that needs to be acknowledged. It's something that needs to be addressed. And we should not rationalize and justify behaviors of bullying because we're saying that this standards will be dropped. This is in the name of keeping up standards. This is in the name of improving. We should really look at how to actively address this so that healthcare professionals can deliver a higher standard of performance. So really, in conclusion, bullying is a complex type of unprofessional conduct with severe psychological consequences for the victim. And we've seen that psychological and physical consequences. And it happens as a result of a combination of things. We have to look at the individual, we have to look at the organization, and we have to look at what are the systemic issues that are perpetuating bullying to continue. So we have to unfortunately ask, how caring is the caring professions? How healing is the health professions? And how healthy is the health professions? Are we healing? Or are we actually hurting? And through our own hurt, we're hurting other professionals. And we need to look at that and address. So thank you very much. Looking forward to the discussion.
Wow. Thank you so much, Liesl. I think, the Are We Healing this is one of the steps that we're taking to, because we understand there is a problem. I mean, research, you went very well and detailed. I think I would just like for our attendees, we've got a lot of people that are joining us. Please type your question and answers in the Q&A. We'll be able to address them towards the end, especially if it's specific to a specific speaker. We'll just address everything towards the end. Now, I would just like a perspective of from the interested profession. So, Dr. Sandile, I'm handing over to you, Numzan.
Thank you very much, Dr. Mila. I hope I'm audible.
You are.
Thank you. And yeah, thank you very much to Ms. Anthony. That was quite insightful and very well researched. So thank you for that. When I specifically look at the dentistry, bullying, obviously, like in other professions, and especially in the academic space, occurs across three spheres or sectors. Obviously in the undergrad, because there's a power dynamic that exists there, as well as in postgraduate training with registrars, and then with staff as well, But of late, you found that, especially with students who are well organized, you find that the bullying is now starting to occur in the reverse, where students start bullying staff. They collapse structures at our institutions and derail academic programs and force us, enabled by what I'd like to call unscrupulous executives, to push things that are unjust, that don't benefit them in the long run, and are detriment to the unsuspecting public later on, So that's very worrying. Then obviously the big one for me is the staff, and that's really in dentistry. I find that's big. It happens quite often. There are certain academics who are big names, have been in the industry for a long time. So anything and everything that they say is the gospel truth. And you shouldn't dare question such individuals. And when you do, all hell breaks loose, and that happens quite often. I look at a personal example for me was, I once watched a colleague being bullied, and I called it out in a meeting, but the bullying turned. Then it was on me, because I how dare I say something, to the extent where a very senior staff member said, well, if I don't agree with their views, I should resign, you know, and I found that very shocking that such a senior person would do that. Now, although there are structures in place at our institutions to report these things, when bullies are high up, they tend to hollow out and repurpose these structures so that they can actually continue with their bullying. So even your HR is collapsed. They themselves are afraid of the bullies. So and this happens because we find that the deans or deputy deans and CEOs then tend to all be in either it's one person or they hold the views that many of the staff are not agreeing with, but you know, because they're the ones who hold the power, will ensure that these things that you know your voice is not heard, and no matter what you put out there, they'll try to find a way to sugarcoat it. Oh, perhaps they didn't mean that. And as we all know, bullies are very quick at times, I found, to apologize, but it's not a meaningful apology because tomorrow they go out and do the very same thing again. And we know that a sincere apology is marked with a change in behavior, but bullies just don't change their behavior. And yeah, unfortunately, in dentistry, most of these people hold these titles. They're professors. They're the ones that taught us. Now, when you think differently and you hold a different view, you know, they go to the extent where they tell you that, listen, you are my student. I know your weaknesses. You can't tell me that. But excuse me, I've advanced myself. I've taken on the opportunity that I've been given to learn more. The fact that now I know and I'm telling you certain things, you should have been proud. But no, they want to stifle your progress. And I think in future research might show that under bullies, there's very little advancement of junior staff under bullies, because everything and anything is about the bully, you know. So I think globally, that's for me what I've experienced in the field that's in dentistry that we're in. Amongst different professions, yes, there is some bullying. We all have little stories here and there. I remember doing my community service where you know, a few of the GPs in the hospital I was working told me, you're just a dentist, you're not a real doctor, what do you know? You know, and this happens. It's a joke then, but I look at it now as a specialist, and I realize that our patients suffer because of such things. I look at the field of craniofacial oncology, where it's dismal how we treat patients with head and neck cancer in this country, because we don't value the input from other disciplines. You know, surgeons just go in and resect. I've saved the patient's life, but there's no rehabilitative plan. There's no psychological plan. You know, has this been discussed with the patient? And often these are, you know, the very poor who have no other alternative. And it's really sad how we treat our public because of this hierarchy that we have. And we think, my discipline is more important than the other. What does he know? His or she knows. It's just a dentist, you know. But, you know, 80% of what you do on a daily basis is around the head and neck area, you know. But now you've gone and you've removed that. How do you expect the person to function? So these things happen, and yeah, it's quite unfortunate. But we do definitely need to find a way to get around it and manage it. I think I've said a mouthful.
Oh, wow. Thank you so much. You know, I think one story resonated with me when you spoke about multidisciplinary, especially with surgeons. Remember rotating in surgery, and this guy had to be amputated. And you know, surgeons are not one of the most patient people around. They're like, okay, sign here, consent. You know, below knee amputation tomorrow. And I mean, those are real impacts on people's lives. And I really hope the discussions that we keep on having on this platform will help us to become better clinicians on the ground, and will help us to work with each other much better. Thank you so much. You were straight to the point and short. I think I'm going to save up some time for more Q&As, I think. Next, we've got Dr. Diane van Zaten. Sorry, is she? Oh, yeah, sorry, I can see you on my screen. Yes, please go on. Thank you so much.
Thank you very much for the opportunity. So I'll give a little bit of insight into, you know, the experiences I've had coming from the profession of optometry. The profession of optometry historically wasn't really part of, you know, the health system as such. Has always been, until probably 10 or 15 years ago, seen as an elitist profession, you know, kind of quarantined to the private sector. So our challenges are maybe a little bit new compared to some of the other professions who've been working alongside other health professionals for a long time. But, you know, to the topic at hand, I think academic bullying or bullying in the workplace, as has been presented by the keynote speaker, is rife. It exists. Academic institutions, by their very nature, that have a hierarchical structure, you know, and academic rankings that feed superiority complexes, create an enabling environment for bullying and for bullies to enact, you know, this intimidation on particularly younger staff or newer staff. So in optometry, for example, you know, my observations, not my personal experience, but my observations have been that typically younger staff or new staff that come into an academic environment are almost automatically silenced, muzzled. There's this perception that because you are new, and you have no academic experience, you know, your opinion doesn't count. What do you know? We've been here for 20 years. You know, we are the experts, as Dr. Sandile said, you know, or you've only got a master's degree and I've got a PhD, or you've only got a bachelor's and I've got a master's. And while these things are not said overtly all the time, but it certainly is attitudinally portrayed. You know, another instance that I've witnessed quite strongly is that senior staff, and I'm not saying it's only in that direction. I'll give experiences of sort of bottom-up bullying that I've had personally, but I think a lot of it does come from top-down, more senior staff bullying younger staff, where it is like, I've been here for 20 years, you know, I'm a senior lecturer or associate professor, so I will just supervise my 20 postgrad students and you will do all the work in the undergraduate training program. So junior staff tend to be bogged down, overloaded with work. They can't grow as academics. And as I said, so their voices don't count anymore in terms of, you know, transforming this academic environment, bringing in their own personal experiences to shape and reframe how our students are trained. Because suddenly what was relevant 20 years ago or 10 years ago is in many cases not relevant anymore. We do need to evolve with the times. And I feel that there's increasingly a chasm that's developed, at least at UKZN anyway, that I see across the health professions, where you've got the newer generation of academics who are progressive and don't subscribe to these old hierarchical structures, are not big on titles and rankings and position. They're there to be part of the change, to be part of the new generation of academia. And then sort of the older guard who believes that this structure is the gospel, as was said earlier, and are trying to retain those power relations. And I'm not sure if that comes from just a resistance to change or a need to just maintain their positions of power, a sense of intimidation that they may then be outsmarted by younger academics who come and surpass what they've accomplished in their careers. I don't know the reasons behind it, but it's certainly my observations across the health professions, and what I've seen also in optometry specifically. When you look at our undergraduate training program, I'm sure with most health professional training programs as well, we rely on clinicians in practice to come and support our undergraduate clinical training program. And even there, I have observed this bullying of staff, sessional staff who come to support the undergraduate training program. Or because you're not a full-time academic, you're not really an academic, you're kind of just here to help us, And so there's this looking down on these clinical staff who just come there, for the most part, with an undergraduate degree, but years of clinical experience and value to add. But there's this power relation that's reinforced continually. They are not brought in as part of the team. We are a collective team in training our students. Again, things that are outside of their scope as sessional staff are imposed on them. At some point, staff are these part-time staff are having to do rosters and things like CPD administration, which they're not employees of the university, but they end up being bullied into roles and responsibilities that are outside of their contractual relationship with the university. So I think it exists on many levels amongst academic staff and between full-time academic staff and then sessional support staff who come in on a clinical basis. And then if you look at, within our profession, we run a campus-based clinic, but we also take our students out to hospitals now. So a lot of our clinical training is happening now in mainstream hospitals. And there more we're finding that the bullying comes from other professions. In our case, particularly from the profession of ophthalmology, whom we should ideally be working closely with. But there's a historical animosity between the two professions. I don't know if it's from a position of professional rivalry, a lack of understanding of the scope, particularly from the part of ophthalmologists not really knowing what the scope of optometrists are, where the boundaries end, not wanting or seeing part of optometrists' diagnostic scope infringing on their own scope. And I think that's so counterproductive to comprehensive patient care. At the end of the day, we are all health professionals who are there to treat patients for the good of patients. And we should be looking at ways we can complement each other rather than putting artificial boundaries. And very pervasive bullying that I've personally experienced and witnessed is that, for example, if we're trying to advocate for expansion of optometry services in a public hospital, and ophthalmology has been there for a long time, literally, optometry will be given a corner, some sort of a dingy, dark, little small room in a corner, away from the mainstream health services, and you kind of figure out how you're going to do your thing there. And you're not allowed to come here into my space and touch this piece of equipment because this is only for the ophthalmologist, even though it's well within the scope of the profession to use that piece of equipment and to diagnose and treat the patient. It's those kinds of things, but because the other profession has been entrenched in the system, is recognized, is is seen as more qualified. I mean, literally, I've had someone say to me, I'm more educated than you, I've got more degrees than you. And so like, who are you, kind of. So I think we need to get over ourselves. We need to get over our titles. I'm not big on titles. But this thing of I'm a doctor or medical doctors are better than pharmacists or are better than occupational therapists. I think we really need to throw those things out the window. We all have our defined scopes. We are there in the health space for a specific reason, and we need to look for ways to complement each other so that we deliver more efficient, more effective health services, particularly within the constraints we find ourselves in South Africa. We are resource constrained. We have lots of challenges. Rather than pulling each other down or putting up barriers between our professions, we need to look at enablers for better healthcare. And I think, and a lot of these perceptions have historically been passed down. We came there, we inherited this artificial, sense of respect to hierarchy within the health system, that these people are more important than those people. I mean, I remember I've been in optometry advocacy now for 15 or 20 years. And, there was a time when our profession specifically resisted the term allied health, being housed under this term allied health professions, because they're like, why are we allied? We also health professionals. We're also there to see to the patient. So what makes one profession a mainstream health profession and the rest of us are sort of just by the way, allied health professions? So I think it comes down to terminology. I think Dr. Sandile also touched on that. And so we really need to start digging into these issues that feed this culture of bullying within academic and clinical workspaces. So thank you. I think my time is up. I wanted to mention a little bit about bottom-up bullying, and I'll just take 30 seconds to do that. I think bottom-up bullying exists. I've personally witnessed it, where as a line manager, staff member, was openly bullying me to the point where I found my hands were tied. Even HR wasn't supporting me. And in bottom-up bullying, one at least has the recourse to go to HR. Unfortunately, in top-down bullying, there's a sense of intimidation. If I report this, what will the repercussions be for myself? So it's quite tricky when one is the subordinate and is the victim of bullying to have to report that. Thank you for the airtime.
Wow.
Wow, yeah, same sentiments. I think, sure, yeah. When someone says like, you don't know anything, you're just like, can I just hold myself back? But anyway, we're not here about the physicals. But I think what's coming out more from the speakers is that this is a problem, number one. And secondly, there are many facets to the problem. Because now we're health professionals, yet our patients are in a bad state of not being treated optimally because of our infighting that we have, especially a profession like ophthalmology. I mean, it's one of those professions where it's disciplines where it takes so long for someone to get the help. And by the time they get it, most times there's like already permanent damage and there's little that can be done. But thank you so much for that. Now we're going to move over to our drugs and pharmacy profession. And I'm going to ask Ms. Babala Pamela to just, tell us what is going on in their profession. And please don't forget Q&A at the bottom. We're getting some questions and they're very positive questions. We hope our panelists will be able to help us towards the end in answering them. Thank you.
Thank you, Dr. Mila. I'd like to thank everyone who's here and the opportunity to share my experiences. I've got a disclaimer that I wanted to share. The views expressed are mine and mine only. It is not based on any specific organization that I've worked with, that I'm currently working with, and the one that I will be affiliated to in future. So I really need to make that disclaimer before I start. And yes. Thank you so much. So whatever that I'm going to speak on, I didn't really touch on the academic side, but I thought I will speak on the experience that I have in the workplace, because I have been in the pharmaceutical industry, like Dr. Miller has said, over 15 years. And you can imagine that when I started at Aspen a while ago, it was really not fashionable to have a young pharmacist then who is in the production. So I worked for Aspen first, and my experience there is that bullying is not really from the colleagues in the production. It's mostly because you work with males. So can you imagine you're coming at 11 o'clock shift and you have to work with these guys and tell them that we really need to push this production. We have about 7 batches to have by the morning. All of this must be done. So my experience there was that it doesn't necessarily have to be your colleagues, but it could come from bottom up. So you experience that then people are just sabotaging everything that you're trying to do. And really it's such a difficult experience at times that people who are supposed to help you are really not supportive of you. Then what I also want to share is the experience in the community pharmacy, where you get bullied by the patients that you are helping. Those are the people that they have to entrust you with their health. But at the end of the day, that normally comes from gender, the language, and the age, because you find that someone who is really old will not look at you the same way. You have your name tag, yes, it says pharmacist, but they'll still say, can I speak to the real pharmacist? You're like, oh my God. Like, am I not a real pharmacist? Like which pharmacist? And then it escalates to the fact that when you say, yes, I'm a pharmacist, then they will be like, can I speak to your manager? You say, I am still the manager, so you still have to speak to me. Then they bully even further, because now you're fighting with the person that you're supposed to help. And I like what Dr. Miller said in the beginning, that there is more UWC. So for me, in my training and in the workplace, you find that there are not so many people around who studied and graduated in UTW. You will find them more in the coast, and they normally work in KZN. So coming to Joburg and working in Kimberley, I was almost like the only pharmacist who ever studied in UTW. So you get a little bit, people ask you, how do you even know what you're talking about? You're like, we studied, this is the same. Unfortunately, the School of Pharmacy has the same type of rollout in our education system. So it doesn't matter where you studied, you will always share the same thing. It's such a mind-blowing thing that people would believe that this university is better than this one, the training from this university is better. So I find it more in the corporate setup, where the bullying now is about the educational background, your experience. So for me as well, it's like when you move from the generic side to the innovator side in the organizations, they tend to look at you like, what kind of training did you get? Because you're coming from generics. We are the innovators, so probably you need to know less, or they need to know more than you. And the experience is really, it's a lived-in experience whereby you just have to always be cautious and always be on the drive that we use the same guidelines and the same requirements. When I register a medicine, it's the same guideline you look at in both spaces, the generic side and the innovator side. So to preach that, it's quite like you either on the receiving end, or you on the other side, or you're just protecting yourself that I don't want to get involved, because at the end of the day, I'm not part of this whole innovator generic, or I'm not part of which university you studied, how much do you know? And you also get bullied by the stakeholders as a regulatory pharmacist, where our health authority is I think it's the longest, it takes the longest in the registration of medicine. And you have your stakeholders in the commercial space who wants to sell a medicine, and you're still talking about it not being registered. It's like every time they know that, oh, we're not regulated, will not do their part. So it's not necessarily now being about you. People are coming to your office, people are asking questions, and there are people are bullying you because you're costing them money, you're costing them time, whereas there's not much you can do about certain things. So the bullying comes from there, as well as when you have to now, you have a product, you need to release the product. There are certain things that, because especially you look at it holistically, where we don't have so many laboratories that test locally. A product comes to South Africa, but it needs to go back overseas to be retested, and everyone is waiting on you to have this product in the market. And everyone's anxious about the time you're taking. I've had to sit with CEOs who come into my office and ask me, where's the product? It's like now you feel bad, and some people will even call it out and say, if it's not done today, then you might decide you either here or you might as well resign, because I need to, like, we need the product. So it's all those things that affect you, not necessarily because you don't know what you're doing, but it's beyond your control. So what I've just touched on are some of the experience between people that I've spoken to and people that who have had the lived-in experience on these things. And the impact it really has, I liked when Ms. Anthony touched on the impacts, because you really get home with this sense of inadequacy. You don't even know whether, should you really go back the next day? What is it gonna look like in the office when you come in and you still say the product is not registered? So it also affects your mental health, because you don't need only to worry about what you can control, but you're worried about things that you don't necessarily have control over. So it's such a big deal when I thought of how much we look at it and we put it at the back of our minds, but it's something that would really, it strikes a conversation where we have to look at it in a way that, is it really being looked at? Are we really being protected as well in the profession? And on that, you would rather, because you know that there's a shortage of pharmacists anyway in this country, I can move to the next one. You just tend to like, okay, I'll go to the next better organization. And if I feel like this is not good for me, you tend to move to the other one. So it really just results in a high staff turnover. And we all know each other. You're like, oh, so you're here now. Also, it's like, it's not good though, at the end of the day. And it poses risk of legal issues, because you always now have to write things down and you have to substantiate why you're making the decisions you're making and the rationale behind why it's not done the way everyone else and the stakeholders expect something to be done. So when I looked at the lessons, you know, I was like, if something is not written, it never happened. This has happened to me so many times, especially in clinical research. If it's not written, it didn't happen. You must know that if you can't produce an email, a memo or something, then there's no one who's gonna speak on your behalf. As well as when I looked at our pharmacy professional conduct booklet, I looked at that and I was like, there's everything that's there, and they speak on so many things, but there's nothing on bullying, and pharmacists get bullied all the time. So it sparks another conversation that, you know, when are we ever gonna look at this, and when are we ever gonna do something about it? Do we really need to have a role where people will write and complain and do, we know that there's research being done, but how much of it comes back and how much of it is being reviewed and being looked at? So it's something that I hope that everyone here will also think about. Those who have influence will have to look at it in that way. In closing, I have learned that people forget what you said. People will forget what you did, but people will never forget how you made them feel. I'm a testimony of that, because some of these things that I speak of is things that I've felt over the years, and it just sticks with you. You're just now so conscious around what you say, and you always need to look after your back. So is it how we really want to see ourselves? Are we really being a health professional, because that's what we call ourselves? Are we healthy enough being the health professionals? That is my question, and that is my take home in conclusion. Thank you.
Thanks so much, Ms. Pamela. Sure. Yeah, I think this topic gets so heavy, like time and time again. Like it doesn't get, you think when you talk about something, it gets lighter. But I think the biggest thing is the fact that it's people's experiences, it's real experiences, and especially how, how are we making people feel? Not just how the bullies are making us feel, but how are we making even our subordinates feel, or even the people that are above us? Because what's coming up, which actually Dr. Nyati was not that big in the first installment, was the fact that there's also bottom-up bullying. And how do we address that? And, how do we even talk about it, that you do have the rights to voice your concerns, you do have the right to fight for fees must fall. But in doing that, how do you make sure you don't disrupt your seniors' way of thinking about, how they deliver, and also just how we not disrupt the system for the other people? But yeah, more dialogue and more conversations to have. Right now, I'm going to ask Ntate Amashudu Nemakanga, our occupational therapist, just your expertise on the subject, and especially on OT and occupational therapy. Thank you.
Thank you so much. I'm not too sure if I'm audible enough.
Very audible. Thank you.
And I'm not even sure how much time are you giving, because our job is to talk.
10 minutes.
I'll let you know when. Don't worry, something will pop up when it's time. I make sure.
Thank you so much. I'm going to share my experiences from two spheres. One as a clinician, two as an academia person. As a clinician, one of the things that I've observed is that indeed there is a lot of bullying, particularly from doctors, where they think that below God is them, and then we underneath them. But from occupational therapy point of view, I think part of the bullying is that we as an occupational therapist invite for that bullying. One, as much as our profession is not well known, I'm not too sure how much do you know about our profession. I'm sure you know this a little. So I think from occupational therapy point of view, we need to make this profession known to the people, because in the hospital setting, you find that not all healthcare professionals know about it. Then how do you expect referral system to be effective there? Overall and above, what I've realized is that you cannot say anything to the doctor. The doctor will tell you that I've never seen you in the class of MBSHB. So what will you say to me? And you find that we are only healthcare professionals. And I'm also glad what Dr. Diane spoke of allied. Allied to me is more of an alliance. But in the healthcare professionals, we cannot embark in that alliance relationship. We are all equally healthcare professionals. You have got your unique role to impact in the life of that particular client. I have got my own role. I mean, if you are a doctor, your role is to save life. Who will make that life worth living? And this is where me as an occupational therapist must step in to bring about purpose and meaning, because post trauma or incidents or injuries, you need to still make the life of that particular individual worth living, and then try to restore functions and purpose in that particular individual. So what I've seen again in the healthcare professionals, that because of these bullying practices, unfortunately, it compromises the referral system. You need to beg for patients to be referred to you, which is not supposed to be the case. And it delays the recovery process. And in the process, it again causes disability, and ultimately some of the clients die. So I think bullying, it is a critical topic that should be spoken about unapologetically, so without fear or favor, because in the process, people are suffering, and we have to bring about change. Let me move to the academia environment. And here, I'm also making a disclaimer, because I'm going to talk about what I, myself, and me have experienced. Yes, I have a lived experience about bullying. When I first joined academia, you know, it is a whole shift from clinician to academic environment. And at that time, you find that you are anxious, not sure, feeling of doubt, incompetence, when you compare yourself with the other academic staff member. But guess how I was welcomed into that environment? I was told that if it was not because of this particular race, you wouldn't be sitting in this position or post. So that was the welcome I got. And then secondly, there were cases built against me as much as I was incompetent, where I was told that I'm plagiarizing students, I'm using somebody else's notes, and I'm not even acknowledging the scholars or the authors. And these were the things that I experienced that were built against me with an aim of getting rid of me. But for some reasons, that did not materialize, because if you are determined, know why you are there, you will stand your ground. But the other thing that I have observed is that you find that there is this unbalanced academic roles, you as the lecturers and as the researchers. You find that there isn't a time that you can strike to bring that balance between the two. You're expected to publish every single year. You're expected to teach, yet you have not accumulated as much experience as you are supposed to. You are just thrown into the deep end, and there was a little a form of support system in that regard. So these are the things that I have experienced, and in the process, you experience things like burnout in the process, and then you are also less productive, feeling of intimidation. And one of the things that I've observed again is the unbalanced or unequal work distribution amongst staff members. You find that there is this particular staff members who will get this less work or the work that they can manage, but you get this much. And in the process, you experience burnout, a persistent headache, as well as heartache, because you spend lots of times trying to balance the role of being teacher and the research, and you end up compromising your family time, unfortunately. I almost lost my wife because of this unbalanced academic roles as teacher and researchers, because I had to find a way to catch up because the workload was so overwhelming. And these are the things that I have experienced. When you find other co-workers, they've got a manageable work, but you have this so much work. And the other thing that I've experienced then is the attitude towards change. Is it that when a new person comes on board or join you as the staff, of course that person is coming not empty-headed, but it's a person coming with, doesn't matter it's a little experience or a knowledge, but that particular person is there to add value or to bring about change. But you find that the attitude from other staff member is bad to a point that whatever point you raise, it's valueless. Who are you to tell us this? And that really discouraged and killed staff morale. But in addition to that, is what we call academic culture and meeting expectation. I was told that you are entering into our ancestral territory. When you go to Rome, you do what the Romans do. Regardless of what they're doing, it's ethical or unethical. And I had to battle with that particular culture on how things are done. Because when the new staff member comes in, he or she has got a unique world view or the way they can also take the department to a greater height. But now you are expected to embark on that cultural practice in terms of the demands, rules. And I had to experience that and had to live with it as an academia person. Of course, the last thing is the distribution of resources, where there was also an equal share of resources in the workplace. Yes, mistreatment was there, I experienced it, and I was vulnerable to those bullying. And these are the things that I have experienced as an academia person. But the only lesson I took is that in the midst of the storm, this is where you become the product of your enemies. And this is where you grow stronger character and personality wise. But we should not tolerate these practices because they are not human and they do not do any good to humankind. So hopefully through people who have power to bring about change can do so that the working environment can be conducive and we can all work to the best of our ability and optimal. I don't want to repeat what others have said, but I just wanted to share my own perspective. Thank you.
Thank you so much. And that's why you are here, to share that perspective of how people don't even know what OTs do, you know? They'll be like, who are those? They don't even know the office of the OT is in the hospital. You'll have a guy that has had a stroke, but internal medicine doesn't even think of speech therapy and OT and physio. And, you know, I think one thing I appreciated about psychiatry is that all the consultations are with everyone, multidisciplinary team. And unfortunately, in the other disciplines of medicine, they sort of lose that. And I think it's really up to us to instill that as we go and practice in clinics. Thank you so much. That was very insightful. And the experiences that one have, because for people that have not been in academia, you don't understand that every year you have to publish, like, you know how long it takes to make research. So that gives a different perspective now, sort of like a more appreciation and respect to the academics out there than me sitting here and not publishing anything. So next is Umama Chona. Yes, Mosula, thank you so much. Our Miss Nightingale, giving over to you, Ma.
Well, I should have brought my lamp then, huh? Can you hear me? Yeah. All right,
Yes,
thank
Mama,
you.
we can hear you. Thank you.
Thank you, Siviwe and Fundile, for inviting me to share our experiences within our profession. Most of you or everybody knows about our profession because it's a very important profession. But traditionally, we were trained not to answer. And so we carried on with our work. But I must say, the hierarchical structure has been a problem, as it is a problem in other professions. But within the curriculum of nursing, I must say it's a very good curriculum. From the time I started training, which was in 1968, we were taught how to work within a multidisciplinary team, respecting each other. But we knew that the patient belongs to me, and it also belongs to other members of the team. And even within our curriculum, all areas of care were mentioned. And I trained in academic hospital. This is where medical students, physios, and everybody was there. And I know that nursing is a downtrodden profession, but for me, it depends on your personality. In other words, are you a confident person? Where were you brought up? And what are your aspirations? So I never felt undermined by anybody. I respected everybody, and everybody respected me. Except when I started to be a manager, that's where the problem started. Because to start with, I was a young Black manager within, I would say, for lack of a better word, white environment. So it was like, I must be happy I'm given this position, and I was not given work. And so my superiors would come and check on me. Are you enjoying your post? Up to a point that I wrote a grievance letter. So in public hospitals, I think also in private hospitals, there's a grievance procedure. It's a beautiful procedure where you articulate clearly what is your problem. And that problem or challenge needs to be solved within a specific time. So it went from me to my immediate manager and all the way. And the issue was resolved and I was given work. Then I moved from that position to go to the UCC. Was also the only or the first Black nurse at UCT. And I was confident about what I'm about to do here, except that the environment was alien. But I'm a friendly person. That didn't threaten me. I had worked with white people before. But something very funny happened. The professor colonized me with prayers and scriptures. I think no one mentioned this one. And my colleagues were quick to see that, yeah, because I was there in 1992. So she thought maybe I'm sent by the ANC to take her position. Yeah, so she was threatened, yeah. Anyway, I listened to all what she had to tell me. She knew everything about me. She was very kind, but I could see through that she's scared of me, you know, more than anything else. But now, besides when I was getting used to university life, I started researching. They didn't like that. They didn't like that. Yeah, up to a point that one of the transformation officers, I think it was Rampele at that time, was called in. So we sat around the table. They're saying this and this and that about you and rah, 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 rah. Anyway, that was not resolved. I was helped by a colleague who was working in public relations, and she said to me, write a proposal and take it to the Vice Chancellor and you'll have an opportunity of going abroad. And I did that. So I went to UK for 3 months on a sabbatical, and I was supposed to come back and be in the Department of Primary Health Care. But I couldn't go back there now. The doors were closed. So I stayed at home and I realized now I'm going to get depressed, and I jumped the ship. I went to work for an NGO in Salt River. Anyway, I enjoyed myself there. From there, I went to Natal through a request of a medical colleague I was working with to say, go and take a manager's post there, and I'm going to support you, and I'm going to be working from Cape Town, blah, 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 blah. Anyway, I went there. So my duties were varied. One of them was to sign and approve all the equipment that was bought for our facilitators. We were dealing with a district health system. So if one time I did not want to sign for an item which I thought was not allowed, and my boss said, Mosula, sign, and I didn't sign. So there was a big fight. Because I'm assertive, I would not give in. They found all the ways of pushing me out until I was out. Yeah, I'm reminded of these issues because now I'm healed. I had forgotten about them. The tables have turned now. The matrons who used to bully the junior nurses and the sisters are being bullied by the nurses and the junior sisters. It is not a good scenario because patient care is compromised. Yeah, patient care is compromised. I must say, I am ashamed about some of the stories I hear about my colleagues. And there are many issues to this. Some of them, you have mentioned them. Because they've been bullied for a long time, They are burnout, and there's staff shortages. You know, it is a very bad situation. Also, the type of nurse that we recruit nowadays is not, what is the word? Their level of education is not good. If you compare our metric and their metric, they are not comparable. I wrote a JMB. And now I must say, teaching them later on, I found a big problem. They could not think critically. If you were trying to teach some concepts, they could not grasp them. And at the same time, I believe they are not good doers, you know, excuse me. And so nursing is at a crossroads because the public has what is the word, has complained about this to the council. The curriculum has been jacked up. Not only the curriculum, the point of entry. It's only people with matric who must come in and they must have certain grades and certain subjects and all that. But I can see that this is going to result in big shortages of nurses. Hence, we've got private nursing colleges who are trying to fill up the gap. But I've seen bullying generally in the wards, especially professors. They were not only bullying nurses, they were bullying doctors. One professor used to even swear to doctors, I'm telling you. So, but if you are assertive and you know your work and you take out your, they won't swear at you, they won't intimidate you. So it's like the survival of the fittest. One of the concepts I was taught right from the beginning, that as a nurse, we must be advocates of patients. I can remember in one hospital in Alice, one doctor was very rude to a patient who came from the rural area. And this patient had anemia. So this doctor brought this machine for taking marrow from the sternum. And this old man is so fearful and does not understand. So I said, doctor, wait a bit. Let me explain to this gentleman what this is all about. Yeah. So really, our training is very comprehensive. It's the nurses who are not putting it into practice. Even management practice is jacked up to business management practices. Yeah. Yeah, can I stop there? And then maybe.
Thank you so much, Mama Musala. You know, guys, we've got a veteran over here. You know, for them to think that you are part of the spies sent into, yeah, it just speaks about your character and how resilient you are. And I think many people like you are needed, and thank you so much for those pearls of wisdom. And you know, yeah, it's one of, I could sit on your feet and just listen the whole day, all these stories and what you've gone through.
Yeah, I didn't even mention the trade unions. Yeah. Yeah, no, it's because the nurses, they've resorted to trade unions because no one is listening to them.
Yeah. But thank you so much, Nasi. I would like, yes. Then next up, final panelist for tonight. Yes, please keep your questions and answers coming on. We've got Mr. Nzikele Lopefile, and he is a physiotherapist and will be giving us just some insights in physiotherapy. Over to you, Nziki.
Thank you, Dr. Mila, and good evening, everybody. My name is Nzikele Lopefile. I am a bully and I am privileged. And I will unpack my statement as I take you through my career as a physiotherapist, and starting from my experience as an undergraduate student, Although I am not going to mention the institutions, but I think everybody knows me, and they would know exactly what I'm talking about and where I've been. So, so for me, the disclaimer would not necessarily work. Yeah, as a student, I was at UWC, and I've never felt that I was treated differently because of the color of my skin. However, there were instances of bullying, between the, as a student and the lecturer, so in terms of that power dynamics. And it will come in a very subtle manner. For example, in the marks of that you are given for an assignment. And people that know me, I'm very vocal, and I would go and go and ask, why did I got 50% for this assignment? And you would understand at that time at UW, we did not have a very good medical library. So we would go, when you have an assignment, we have to go to UCT and go to Stellenbosch library to get the information. And for you to give me 50%, no. But now on those days, there were no rubrics. So they will just give you a mark, but I will definitely, question that. And the other instance would be during the practical exams and during clinical exams. I would be finished, because the intimidation that you get during those clinical exams or practical exams was, it paralyzed me when I had to get to those exams. But you had to do the things, and then you have to move on. And carry on. And also the other thing that came through as an undergraduate student is when, during second, third, and fourth year, we go for clinical rotations in the different hospitals. And in the Western Cape, those clinical rotations are shared by the 3 universities. UWC students have always felt inferior when we get to those clinical platforms, and we will be treated differently. And you would know that the UCT students and the Stellenbosch students were given the first preference. So they were the first class citizens of the physiotherapy world. And we just had, as UWC graduates, we just had to follow behind them. And we carried this as we progressed, and I worked as a junior physiotherapist in a big hospital in Joburg. And so and amongst the staff within the physiotherapy department, there will be that classism. Which university are you coming from? Oh, you from VET? Oh, you from UCT? Oh yeah, shame. From UWC, shame. Yeah, we'll start you in this rotation then. So that we can build up the experience, so that we can now be comfortable of sending you to neonatal ICU or to general ICU. Yeah, and then I left the public sector, and I joined Medunsa. Now, I joined Medunsa. I did not have, as a junior lecturer, I did not have any experience as a teacher. So my point of reference was my education. And so in the first few years as an academic, I mimicked the way my lecturers had taught me. And guess what? The bullying cycle started. I was the victim, and now my practices now as a lecturer they were exactly the same. And so all my students will tell you that, oh, Mr. Pifla, oh, practically, just, the students will be petrified. They were petrified of me when they have to come to class. And, that's one of the things that I had to reflect on as I was preparing for this. What was my contribution throughout as a bully? Yes, I've been bullied, but what was my contribution as a bully? And I was so ashamed to actually, when I reflected, to think of my practices, during the prac exams, as we are preparing the pracs in the gym, SSP at Medunsa, and the way I would stand there and posture myself, next, that kind of, and it was all the way of commanding respect, because I was this junior lighty, and the students, some of the students were of my age. So I had to now act as if, yeah, I've arrived. But when I joined UKZN, I think for the second time, we were made to reflect on our teaching practices. And all the academics at UKZN had to go through some series of modules so that we can be able to reflect on our teaching practices. And then the change started to happen, where I now see the students. So now I was introduced to teaching and learning philosophers. And then I realized, oh, actually, a student can actually bring something on the table, and I can learn a lot from my students. And then the dynamics and the interaction changed from that experience. And then at UKZN, I don't want to lie, I had never felt bullied, because at some point, I think one of the reasons was that I had so much institutional knowledge, because I've been there for quite a long time. So anybody that was trying to bully me, I'll just pull up a policy, and I was not afraid to take on anyone who was trying to bully me in the department. But then I had to leave, and then Mama Mosula, I had to join your previous institution. I won't mention the names. And yeah, then the things got a little bit different. Then I realized, actually I am Black, and and it was made very clear to me that I'm actually employed primarily because of the color of my skin. So I was employed just to come and fill up at the space so that the employment equity would look good. And obviously now, when you start now, and you are being put in the box, and when you start to rattle that box, obviously there will be now microaggressions, and they will, try to small up until to a state where I was actually clinically depressed, and had anxiety.
Oh.
And then I had to choose. Do I stay here? And if I fight, if I put on my fighting spirit, am I going to win in this institution? And then I realized, hey, there was Professor Mayosi, and he is no more. And then I decided to jump. I said, this is not for me. This is now too big for me. Let me run away. So and I have, but even in the other institutions, I've also watched and observed not my colleagues from other departments being bullied, being belittled, being manipulated. As a young academic, you get manipulated so that you feel comfortable under the senior professor, and then but when you want to start to question things now, and then you get the alienation, and also people, the senior professors will take credit for work that they didn't do. And people were made to feel inadequate to an extent of wanting to resign from academia. But the only thing that we could do in those instances is to give the support, and to give to those colleagues that, and to keep on reminding them of their worthiness and of their abilities, and and you try to, for example, to write a paper with them so that they can be able to see their worth, and and to divert their focus on other activities that are going to make them productive. Yeah, that's my story. I'm privileged because during my tenure, at that place, I had so much support from my friends, and so much support from my ex-colleagues at UKZN, and from the profession, because my ex-lecturers from UWC are the ones that have actually given so much of support here in the Western Cape that I even ended up going to another institution where I am now, and I'm happy now. Thank you.
Thank you so much, Nziki. Yeah, that was a nice spin, eh? Where you're actually talking about the flip side, where you are the bully. But you know, what I find very interesting in everything that everyone has said is how we sort of internalize the bullying, and then almost like subconsciously you want to say, when I get my turn, I'm going to show them, you know, because that's what's coming through. The ones that were bullied actually become the bullies. Whether people have admitted to that or not, that seems to be the cycle. But there's one thing that I think nobody has touched on in everything that has been talked about here: the issue of gender, the issue of ageism, you know, because what chased me out of academia when I was a lecturer at Medunsa was the fact that, just like you, I was young, I was 25 years old, I was a lecturer, and I felt so inadequate because everyone was looking down on me because I was young. Secondly, the students, the male students, because at the time it was predominantly male, which was now a shift from the predominantly female environment. Now my students were predominantly male, and they were hitting on me as a lecturer. And I just felt, you know what? No, I am not going to, I cannot do this. And so I left academia, although I loved it, you know? So those are some of the things that we're not talking about. But be that as it may, I think the issue of institutions, where when you're coming from a particular institution, like they would say, you're from Bush, you're from Medunsa, those are low quality universities. Or you're from UNITRA, no, that's a low quality institution. But people don't even look at what you have to offer. And again, you know, something that is a narrative that's continuing, where you're finding that between the various professions, you know, between physios and OTs, there's been a dynamic there, where either a physio will feel I'm superior to an OT, or an OT will feel I'm superior to a physio. Between psychologists and social workers, there's a dynamic there. Between doctors and other professionals, between doctors, medical doctors and dentists, between ophthalmologists and optometrists, that dynamic is there, but nobody's talking about it. I'm glad that, you know, it was touched on when we were talking about the optometry field. So there's always that dynamic, and it does lead to a power dynamic where others feel more inferior to others. And also the issue of those institutions that don't have all these fields, where you find that, for example, there's a medical school that only has MBCHB, and then the so-called allied health professions are not there. The patient suffers, as everybody has alluded to that. You know, the patient suffers because now I'm not going to refer to a physio. What's a physio going to do for my patient? What is it that they know which is going to help my patient? So I'd rather have a stroke patient that's not going to get rehab because I think I can give medication and the person is going to recover. You know, so all of those things we've spoken about, and thank you everyone for all your contributions. There's questions that have come from our viewers on the floor. I will start, I think between me and Dr. Mila, we'll go through these questions. I will start with a question that came through from Andy Lenzele, who says, how can one assertively cry for help in the scenario of a superior and subordinate, considering the impact of victimization? And yeah, so that's a question that Andile asked. Maybe Liesl, you could help us there?
Yes, I think that's really well, we better answered probably in a third part of this, where we're looking at, you know, what are the things that one can put in place to address that. But I think it really starts with acknowledging that it's happening, that get validation for the fact that it is happening, and then to get support around you to start speaking out. But I think there needs to be institutional measures put in place that one knows this is the route that I follow in order to actually address this.
Okay, and the next question is from Ndombombuso Sijosingwe. I think you did address it though, Liesl, because this person is asking, can bullying cause a permanent mental disorder to the one who experiences it?
I think bullying has got it can lead to different types of psychiatric illnesses, like we mentioned, depression, anxiety, post-traumatic stress, burnout. So I think it can become persistent if one doesn't address it or get the necessary support and help for it. So that is where it becomes important to really monitor what symptoms do you have, is this ongoing, is it getting worse, and you need to get the appropriate help. You need to speak to people, you need to debrief around what has been happening. So yes, if you do not get the opportunity to actually have support, emotional and mental health support.
Okay, and the next question is from Zandi Leblose. She's asking, is bullying a form of abuse or considered as a level of abuse? If so, why do we not call it such, abuse? Yet it is a behavior, but an abusive behavior. So again, I think Lizzle, you're going to help us with most of these questions here.
Yeah, I think it speaks to the last slide where I basically said, that bullying is a complex type of unprofessional conduct. So I think we really, it's a very pertinent question. Why don't we call it abuse? And I think it speaks to the languages that we also use, that the narratives around how do we name things, should it be abuse, should it be bullying? I think it's probably called bullying because it's unprofessional conduct. It's a type of workplace violence, and complex in the sense that it encompasses different types of abuse. It can be verbal, it can be physical, it can be emotional. And I think that's why they classified it as bullying. So yes, but I do think there needs to be a discussion around discourse and how do we name things and what do we attach to the names? Is it worse? Is it lesser than? Yeah, but that is really a discussion around a myriad of different concepts.
Okay. There's a question again from Dr. Pumeza Gwengu. What are the best coping measures that one can employ at that particular moment of being bullied in terms of interpersonal reaction, whether short-term or long-term? And she says, is it good enough to say you lose respect for such an individual?
Sure.
I think that's a very important question because, once you're in this experience, you're in it and you're totally overwhelmed by it, what do you do? It really depends on the type of person you are. If you're a very assertive person, people would address it and say, I don't appreciate how you're talking to me, or I disagree with what you're saying. It's not always easy to do that in the moment. Then it's always best to remove yourself from the situation and take some time to reflect on it and then come back and address it. It's always time to just take a breather. But I think, one does sometimes lose respect for superiors or people that address you in a certain way, or especially if it's not the first time that it's happened and it's more persistent. But I think that's short term, either speak up and address it or remove yourself from the situation and find ways that is more authentic to how you would respond instead of just responding in the spur of the moment. But I think you need to acknowledge that if something feels wrong, that it's probably wrong, and it doesn't feel right for you, then it's important to address it. You need to find emotional support through peers that have had similar experiences, and perhaps safety in numbers to address it, when it's a few of you that has experienced that.
And what happens if you a lone ranger? if perhaps you don't have that capacity to share, with others that this is what I'm going through, because there are people that have got that type of personality.
Yeah, definitely. When you're more introverted and you're more private and you don't necessarily want to speak up and share with others, or you don't necessarily trust that what you say will be kept in a safe space, I think it's then important to create a psychological safe space for yourself. And you can do that, through debriefing, through your workplace EAP programs, through getting somebody that you can speak to, either a counselor or psychologist, where you have the opportunity then to learn coping mechanisms and some skills to address these issues.
Okay, Dr. Mila, over to you. Please take over. There's a question by Belinda Ban.
Yes. Oh, yeah. Okay. So Belinda's asking, who is responsible for the well-being of joint appointees at academic institutions? Most healthcare professionals at medical institutions are employed by the Department of Health, which at times facilitates institutional abuse. So I think I'll ask Dr. Nyati with this one, and also I can just ask Ubaba Mashudu to just help us with this one, because I think we've had a conversation around this with Dr. Nyati.
All right. Thank you very much for that question. I think it's a very important question, because when you are a joint appointee by the province, but at the same time by the university, it is very easy that you will want to raise issues maybe with the university, and they tell you that no, you are employed by the provincial department. And if you go that way, they will point you to the other side, that we don't have, let's say, the other person who's causing this is maybe a full-time university person, So there's a study that was done and published in April on the South African Medical Journal. It was a study that was looking at bullying in the academic sector, at VET's, Faculty of Health. And amongst the high-risk groups, or people who showed a lot of, or who responded that they experienced a lot of bullying, was the people who are joint appointees, that is province and institution. So it is definitely a big problem, because those people fall into the cracks. So now research has actually showed it, but the question is, how is it going to be addressed? Because you've got a dotted line this way, you've got a dotted line that way. Where is the solid line? Who must take responsibility? And I think it's something that needs to be addressed, so, but at this moment, there is no clarity. I was happy yesterday, I joined in on a webinar from UKZN, which was addressing the same topic. And what I saw there was that they are quite aggressive in creating awareness about the reporting lines when there is bullying, all the way from your immediate, manager, all the way up to the DVC. So if one level does not give you the necessary, response or support, you go to the next level. You go to the dean or to the head of, of school. And if there's nothing there, you go all the way up until you get an answer. So that to me, I found quite progressive. But again, Ntsiki and Dr. Wallace, Van Saden, they are from that space. It's one thing to have the policies, and clear, reporting lines, but how are they communicated? Are there things that are in the intranet, or are these things that are made available, so that people can be able to know the channels, so for me, I think, it's important to explore both, the university that he has employed you, but also the provincial government. Somebody must answer. But I think, we are going to have a third installment of this kind of webinar of bullying. And there we are looking at, getting somebody from the International Labour Organization. We're looking at getting somebody from the Human Rights Commission. We're looking at getting somebody from the Public Protector Office, and also the Health Ombuds. There's something that was mentioned, I think, by Liesl earlier, that maybe having an ombuds who is not necessarily linked to an institution could be a way to go for all healthcare professions. And maybe expansion of the mandate of the health ombuds could be one of those possibilities, which is why we're going to invite him. So that it doesn't matter if you are jointly appointed this way and that way. At the end of the day, you can send this thing to that national health ombuds who must then make sure that things happen. So those are my thoughts at the moment.
Do you have any thoughts, Ntate Mashudu, on the subject?
Thank you so much. If I were to influence the policy, I would say this practice must just be stopped of joint appointment, because in itself, it is a form of bullying. In the former university I used to work on, there was one staff member who was appointed on that basis. And the bullying practice that she experienced is that the amount of workload was big to an extent that the money that she was getting from the department was this little. And to me, it was form of bullying too. Two, who do you report to when you have some legal issues? Because there are so many implications on this joint appointment. And there isn't also a clear memorandum of understanding between the department and the institutions. And I think this is where we subject poor people on these practices of bullying. And believe you me, if you track down those joint appointments, a person does not last more than 2 years, because it's not a conducive environment to stay in that space. So I think the university and the Department of Health should sit down and find a common ground, because there's so much uncalled for legal practices. So I think it is important that we explore further about this issue, because there isn't even benefit when you are in a joint appointment. So that is another form of bullying that one experiences. And believe you me, the university does not care much about your well-being. They care about you delivering. As to what you are getting month's end, it's none of their business.
Oh, thank you so much. Yeah, I think that's actually quite, we are on the other side and we don't know the integrity. So I really thank you so much for your experiences and being able to answer some of the questions. I'd just like to ask our panelists if we can just have 10 minutes of your time. I know we're running above a bit, but I just wanted to make sure if we can cover a lot of questions. There's some that are coming through even on Facebook. If you just bear with us, just 10 minutes, please. Maybe a question that I can ask Dr. Sandile. And anybody else who feels that they can add on, maybe Diane. Bullying amongst similar health professionals from different training centers, this one is coming from Levine, is a concern for me. Borders more on racism. For an example, one university is better than the other, especially if it's a previously advantageous system. Is this hierarchy system an enabler of bullying? And then just to add on, he also writes, or she also writes, another profound problem I've personally observed is the idea of gaslighting by the perpetrators of bullying, where the victims are actually made to believe that they deserve to be bullied. So if you guys can answer that, maybe.
I think legal and gaslighting.
Oh yes, Liesel can do the gaslighting. So he asked maybe Ms. Anthony can do the gaslighting.
But let's allow others to.
Yeah, thank you. The one about the institutions is, yeah, it's very real, especially for all the previously disadvantaged institutions. We always seen as though we have an inferior product, when often the curricular scope of practice is governed by HPCSA. So we all actually are on the same platform, and from an educational perspective, there are always nuances to each institution, but we fundamentally get the same training. And you get it when I experienced it in practice. One of the few things when I used to see white patients that tell me, oh, I'm pleasantly surprised. Excuse me, why? It's, so, and unfortunately, what tends to happen is, if I'll be bold enough to say this, the best way to advance in South Africa is to be of Caucasian descent with an appendage. Then whatever you speak, whatever you say is the gospel truth. You know, the rest of us, you have to prove that you are alive and that you are not you're not there because of your skin color. You know, you have to constantly justify. So right down to the quality of training, you have to constantly defend the institution that you come from, because you're an inferior product. But I will say, in my personal experience in dentistry, the previously disadvantaged institutions, there are only 4 institutions that teach dentistry in this country. The 2 previously disadvantaged ones are doing amazing work in the sense that they are the ones who have flooded the academic space. They're the ones who are teaching at these formerly advantaged institutions. We've been there. We can do the job. So, and I think that's just testament to what there's character building that's in it, but it's unfortunate that we have to go through that to own and earn our space in the public eye, you know. But it's unfortunate. But I do want to say, actually, the previously disadvantaged institutions are equally as good, because I also don't know what this benchmark that they use as to which institution is better than the other. How are you comparing it? You know, what actually are you comparing? So I don't know where it stems from, but it's a very annoying thing, actually, to be honest.
If I could just add to that. So yeah, I agree with Sandile that definitely it exists. Those historical perceptions of superiority amongst formerly advantaged and formerly disadvantaged institutions exists even now. In optometry in particular, if I think of the one formerly advantaged institution or historically white institutions, who had the top professors who published sort of, you know, very technical scientific papers in international journals. And up until a few years ago, UKZN didn't have a single professor and was very low on publications. So my response to that is, and even to bullying in general, is prove your critics or your skeptics or your abusers wrong by doing good work. Today, UKZN Optometry, I'm talking about just in my profession, as a historically Black university, you know, we have the most PhD qualified academic staff in the country. We're publishing the most out of all academic institutions training optometry in the country. So the only way to silence the voices is to prove them wrong. Work hard, treat the criticisms like water on a duck's back, and knuckle down and just do your best. You know, even thinking of my own experience coming into academia, where there were very few people, I mean, so-called colored people at university, and trying to find my space and acceptance. And I felt like I didn't belong because there were very few people that I could relate to. But the one thing that kept me going, and within Nsiki will testify to this, I found my safe space actually in physiotherapy. Not even within my own discipline, because, you know, I faced things like bullying, and I thought, okay, it was about self-actualization for me. When I was a kid, my father always said to me, if someone else can do it, you can do it too, and possibly even better. And, you know, he drummed that into me. If anybody said anything nasty, treat it like water on a duck's back. So I was just like, I know why I'm here. I'm going to push forward. And if you're going to be in my way, I'm going to go around you, you know, to get to where I need to go. So you just have to develop thick skin sometimes, and then just brave up and confront some of the demons that are trying to derail you and prove them wrong in the end. That's the best reward, when you can surpass the limits they've tried to put on you.
Sorry, I'm still muted. Thank you so much. I think we've got about 3 questions, and then we can hand over to you, Dr. Nyati. Or is that fine?
Even if you can just continue and close it, use my 5 minutes to answer some questions, then I'm good.
Okay, no, that's fine. I think, Barbara, can you help with?
Can I come in there?
Yes.
There's something that I wished Lizzle would address, because last week, the other time when Dr. Sifumba spoke about this, I felt there needed to be more stuff said about it. The issue of gaslighting. You're made to believe that it didn't happen. You're made to believe that you deserved it. You know, she spoke about that, and I really think that maybe Lizzle could assist us with, you know, either tools where one, you know, can empower themselves on how to deal with it when somebody's gaslighting you.
I think even the name gaslighting, maybe what is this gaslighting?
Well, gaslighting, from my understanding,
No. Let Lizzle tell us.
Oh, okay. All right.
We should have actually let us speak, Doc.
No, we want you.
Okay, no, not a problem. I think it has come up definitely.
I'm using my bullying powers now.
Okay. Luckily, I didn't experience it as bullying, so good. I think gaslighting it's really a psychological manipulation that's being used. You know, and I think we just need to go back again. And bullying is a complex type of behavior. So there's different type of tactics that are involved in doing this. It's not as straightforward as it might seem. You know, people make use of a lot of sophisticated / unsophisticated tactics to actually achieve what they want to achieve, whether it's power, fame, status, whatever the goal might be. And it's, like we said, normally linked to power. But at the psychological manipulation where the person actually sows doubt, and where you then start to question your own sanity. You start to question your own memory. You know, you start to question your own judgment. And it's really happening on a very, very, very subtle level. Sometimes it's quite overt. And you're aware, you know, like we heard in the previous, in part one of the session, where you go back and you're gaslighting me, you know, but it can actually happen quite subtly. So in a sense where you would be given an instruction and you would do as told, and then the person would say, but who said that? You know, and then you would, but you said I need to do this, and now when did that happen? That's not what I recall. So that's a form of gaslighting. And then you start and you think to yourself, and that's where you start questioning your own memory. Did I hear correctly? You know, maybe I misunderstood. And that's where it subtly starts happening. So you caught onto the hook, you hooked. And you really need to unhook yourself. Because once you hooked, that's when it seriously starts happening. That's when the gaslighting just actually gets worse. So in a nutshell, and in terms of, you know, just looking at time, that is really what happens. Where you start questioning your judgment, you know, if somebody would say, no, go ahead, you've got the skill, you know, you've got the experience, just do it. And then come back and say, but why would you do that? You know, and but I've done it before. Really? And then what was the outcome? Okay, that's what I remembered. I remember that actually, you know, does that and the other happen? And you subtly then start to question, did I make the right decision? And then you start second guessing yourself, and that is really the aim. You start second guessing yourself, you start second guessing, and you look for confirmation. You then go to this person and say, can you please assist with this? You know, can you just check this report for me? Can you just check my diagnosis? Can you just check my treatment plan? And that is really the aim. So that in a nutshell, that's gaslighting.
Okay. Thank you.
Wow. Thank you so much, Lisa. Just two questions. I can put it up to the panelists, maybe people who have not spoken much, Ubabalwa and Umama or Mosula. So Nelly writes, I also believe the bullying experience during undergraduate studies can lead to feelings of incompetence, poor mental health. Because of the inferiority complex, it doesn't build a good professional foundation during and after completion of studies. Unfortunately, such bullying may lead to some students to have suicidal thoughts or contemplate suicide. My question is, how can this be addressed?
Come in there, Dr. Mila, you know, what I've learned during my undergrad training, I had a very good lecturer who used to say, you go out there and when they start bullying you, when you return that script back to the doctor, you tell them, doctor, I have IST at the end of my name. So as a pharmacist, it means I am the one who's a specialist and I'm a specialist in this field. So I had this confidence as a young intern that I am an IST at the end. So no one's gonna touch me. What I say is what I know, and I'm a specialist in that field. So that assertiveness helped me throughout my career, when even now when I sit and I know that I can sit in any space and occupy it, because I'm not just speaking because I have a platform to speak. I'm speaking because I've been trained. I have a reason to be there, and I will render the service that I'm trained for without fear of anyone intimidating me anywhere I go. So in as much as we sort of like think of it in a way that there is no any other way, because you can go the legal route, but that takes longer because now you have to prove certain things. So the easiest is that you need to get it from within. And what helped me is that when I go home, I've got people who dearly love me and always cheer up for me. So whatever happens at work, it's work. I deal with it. When I get home to the people that love me.
Wow, thank you so much. Mama Sula, do you want to add on that question?
Yeah, I think assertiveness training will help. People need to open up and share with their colleagues, share with their counselors in hospital situations now. Yeah, I mean, we encourage our children, our grandchildren to open up. So this should be something which is general to everybody. We must not bottle up, we must share and talk about issues. Yeah, it's a pity we don't eat together our dinner, because we could share these issues at dinner. What happened during the day? That's a starting point, you know?
Yeah.
And someone from the family or from friends can have ideas and refer you to a higher level or higher, better channel. But it's not everybody.
Sorry,
Okay.
Sham. Yeah, we're having network difficulties, but I think the essence of it, I mean, it's ending on to what Ms. Pamela was saying, you know, that going home, you've got a support structure and support system. This is going to take time. We are talking about the subject. Yes, policies in place, that's going to come later. But I think the biggest thing that came out, even from the first installment, make sure you surround yourself with people that love you and can support you, especially if you're having mental health challenges because of the bullying that's happening, be it academia or in the workspace. Dr. Nyati?
Okay, now I think if there's nothing else, maybe I should just thank everybody. Thank you, Lizel, for the. Okay, there's somebody that raised a hand, Mosidi. There were two participants. I don't know if you guys want to pick them up, but thank you very much.
Yeah, sorry, there was just something about, can bullying be reported to the HPCSA as it is unethical? And then Mosidi was speaking that it is difficult for the perpetrator sometimes because they are treated more regardless, especially in the speciality, and whatever the person says is gospel truth. So then how does one deal with such a person? I think those were the two burning issues. Those were the two fires.
At the UKZN webinar yesterday, there was Professor Rataimane, who is now the head of the medical board. He actually said, look, HPCSA didn't have a clear position on the issue of bullying. However, within the next 3 months, they're going to be coming up with clear guidelines. At this moment, they will treat it like any other complaint, you know, where there's a what now? But anyway, there's
preliminary hearing.
There's preliminary hearing, and depending on what comes out of there, then if that doesn't work, then it goes full on with sanction. So basically, HPCSA has not clearly, you know, come up with a position, but in 3 months' time there will be.
Sandile, your hand is up.
Thank you. You know, I just wanted to say, I think we all need to realize that we need to call out bullies and call out bullying. You know, when it happens, even if it's not directed at you, you need to be principled and call it out. And the reality is, if you don't call it out, you next. So in calling it out, you inadvertently protecting yourself, because the bully already knows they can't mess with you, you know. And then secondly, as Ubabala said, ensure that there's a paper trail. Once you've said something, follow it up as per our discussion or as per our conversation. You know, on this day, such and such happened. Whether they acknowledge or say noted or keep quiet, it was sent. It's there, so that if something should transpire later on, you know, you've got a record of listen, I addressed this matter in this and that way, but nothing came of it. So that's important. And then lastly, the question keeps coming up, or it keeps being said, you know, for those with power, for those with influence, now nobody has power, nobody has influence. We're the ones who have the power. And that's why you need to call it out, because I've witnessed where deans are bullies. And the only way to report it is it's going to get to the dean, because it can't leave the faculty. But this is the very person you are reporting. So it's going to be stifled. But what you need to do is call it out anyway, follow it up with an email, so that when you do escalate the matter, even if you choose to go the route of the media, they can't say you're taking institutional matters and you're sending up. I have tried to address this matter, and I don't like how I'm being made to feel in this environment. And I think that's something that we need to be strong on.
Perfect. Thank you so much. Great closing words. I think Dr. Nyati?
No, I think mine is an easy one, is to just say thank you, those 2 words, to each and every one of the panelists. Ntsiki, that was quite interesting. You made me laugh. That's why we put you as the last one, you know, and the fact that you admit that at some point you were a bully. Not many bullies actually admit. You know, Mashudu, I love you know, the way you actually called doctors, you know, that they basically undermining your profession. You know, yeah, I mean, for me, in my training, I never came across an OT. The first time I came across an OT was when I was starting this company 21 years ago. So that was my first experience of meeting an OT, and I got to know an OT physios. I bunked some of the lectures, so, you know, I didn't know much, but it helped that my sister is a physiotherapist. So yeah. And Baba Alwa, you know, thank you very much for also giving us, you know, a wider understanding beyond the retail pharmacists that we know, and that even in those spaces, you know, where you guys are occupying spaces that were previously not spaces for people like you and me. You are also still experiencing in a different way and being made to account for stuff that's beyond, your ability, and being made to feel like you are useless. Dr. Wallace, Van Staden, thank you very much. You both work with eyes, you and the ophthalmologist, but somehow one, thinks that they are better than the other. I think there should be more collaboration. So for me, that was, something that was very important, because it's not just within your profession, but also how to collaborate with others within that space. Babu Mpungos, thank you very much, man. All I can say is that whenever you call it as it is, and I think that's how it needs to be, we must not tolerate bullying. Yes, there is a risk in actually raising the staff, but you know what? If you are good and you know why you are there and you are assertive, ultimately, I wrote on my Facebook page that we must make it uncomfortable for bullies to continue. It must be uncool, to be a bully. I know a few who are still smarting from the webinar we had 2 weeks ago, because they have now taken it upon themselves to actually think that they were accused personally. So if the shoe fits in, well, you must wear it. So basically, thank you to all of you guys. Musula, in her absence, thank you very much. Somebody's asking, when is the next webinar? We're looking at a solutions-orientated now webinar, hopefully on the 17th of this, where we will have the Ombud, somebody from HPCSA, somebody from the International Labour Organization, to look at best practice globally in terms of dealing with this matter. So because it mustn't just be a talk show, we need to work towards solutions. So I'm trying to get those institutions to play a positive role in actually saying, in this country, in the healthcare sector, this is how bullying must be tackled. So thank you very much to all of you, and I appreciate all of you, and I hope everybody at home enjoyed your contributions. I really enjoyed. I think this thing about people sharing stories is actually sometimes very, very powerful, because it's real. Liesl, thank you very much for the foundation, so that, my parents were both teachers. They always said, you must define what you're going to talk about before you actually discuss it. But otherwise, if you had just jumped in to talk about bullying without that foundation, some of us maybe would have gone, on a tangent. So that was a very good and well-researched stuff. So thank you very much. So I've got nothing more to say. And to the moderators, energetic Dr. Mila, thank you very much. Thank you. And to the one that was helping you, Pelogazi, I won't say much, but thank you very much. So bullying made you to leave academia. I didn't know. That's the first time I hear about that. But anyway, thank you very much. You're still contributing in a different way. Tsigi, thank you. Mashudu, thank you. Diane, thank you. Babalwa, thank you. Sandile, thank you. And till next time.
Bye, guys. Thank you.
Thank you so much. And also to all the participants. The participants, thank you so much. And Tiki, don't worry, hey, they still popped up and said, no, thank you for teaching them good stuff. As much as you bullied them, they're still thankful that you taught them the real stuff. But we're glad that you're acknowledging. So our work is getting there. One converted bully.
One at a time.
One at a time. Good evening, everyone.
Bye, everyone.
Okay, thank you very much. Thank you to everybody.